Hi everybody, I'm Dr. Deed Harrison of Chiropractic BioPhysics Seminars and Technique and Chiropractic BioPhysics Nonprofit, our Spine Research Foundation. It is December 21st, and by the time you see this, it'll be near or after Christmas time, so just want to say Merry Christmas to everybody. Hopefully you have or had a safe and happy holiday season, and Happy New Year as well. I've taken a little bit of a break doing these CBP nonprofit research video reviews, but we're back in action again, ready to go. For those of you that might be new to these videos, CBP Nonprofit, a true spine research foundation established in the 1980s, is part of Chiropractic BioPhysics Seminars and Technique. It is a separate entity in and of itself though. It's a true 501c corporation that's nonprofit status with the IRS. And to date, we've done just over 160 peer-reviewed research projects. And you can see this table's a little dated. It shows 155 of them. But if you go to our website, you'll see the updated list. What I'm doing in these video reviews is I'm going through each one of our publications in a review PowerPoint style presentation, so you don't have to actually download and read the paper. However, I'm doing more of the Cliff Note version of these projects, so you still are advised to go to the PubMed source, download the paper when available, and read the full text. Certainly reading the abstract is also going to give you some background information on the project, but it's more of a Cliff Notes review if you read the abstract. This week I've chosen one of our publications, or I should say one of our projects. It's not formally published yet in the peer-reviewed literature, but it was presented at 2 peer-reviewed conference proceedings. The last time this was presented was in 2015 at the WFC ECU conference in 2015 in May, and that was in Athens, Greece. So this has been accepted at a couple conference proceedings. The abstract is available through those peer-reviewed conferences, and I'm going to go through this particular project. I think it's very fitting and appropriate to end the year with this particular study. So this is number 39 for our video review. This is the cervical spine in relationship to low back and leg pain. The title of the project is, does improvement towards a normal sagittal cervical configuration aid in the management of lumbosacral radiculopathy? A randomized controlled trial by my great colleagues from Cairo, Egypt, Professor Mustafa and Professor Diab, and then myself, Dr. Deed Harrison. We are going to be looking at how we can affect the low back and leg pain by intervening above the low back. We know the spine is a contiguous system, but oftentimes clinicians and also surgeons, they neglect other areas of the spine. They focused on the area of chief complaint as the primary problem. Well, there is a problem there in the area of chief complaint, but other areas can influence pain syndromes, biomechanics, etc. in that area. In this case, we're going to be talking about how the neck can affect the back. And recently, in the last several years, more and more studies have been coming out in the field of biomechanics, rehab, and surgical papers showing that this indeed is a correct issue. If we can intervene in the neck, we can affect the low back. So here's a study from 1962 by Briggs and Marians. And what I'd like to do is just talk to you about the issue of low back and leg pain that is driven by an issue of a disc herniation. Okay, so I want you to consider, what if a patient had a disc herniation when we look at this figure here? Now this is a cadaveric study, and what we're seeing is the cauda equina in the lumbosacral region. Okay, so the cadaver would be on their stomach or prone, and we've excised and opened up the spine by removing the lamina, by removing the spinous process and the soft tissue, and then they've excised the dura, which is the covering around the spinal cord and the nerve roots. And here is the lumbosacral nerve roots, and you can see the dural covering being excised or exposed, right? So this is a loop of wire that's around the cauda equina, and they're lifting up with 50 grams. And by lifting up, they're pulling from the front towards the back, but they're pulling superiorly. And if this is a 50-gram load, you'll notice there's quite a bit of tension in this system. The nerve roots are not deflected very much by this 50-gram load pulling on the loop of wire. Now this is the same cadaver in the same prone position with the same 50-gram load, but this time they've changed the posture of the cervical spine, which is well above the lumbosacral nerve roots. So instead of affecting the position of the low back, they're affecting the position of the neck. In fact, this is with a nice deep cervical lordosis, the bottom picture, and the top picture is with a straightened or slightly flexed cervical spine. So what you're seeing is when you lose the cervical lordosis or the cervical curvature, it puts longitudinal tension or strain on the spinal cord and nerve roots all the way down to the cauda equina, such that here in the top picture with no neck curve, you do not have the ability of the nerve roots to fold around a disc herniation that's sticking into it. It's stretched tight, and then I have a high load if I was a disc herniation sticking up against there. The disc herniation would be like mimicking the force with this loop of wire, right? It's called a transverse load, so the disc would stick in there. Conversely, if I have a nice cervical lordosis, there's slack in the system, and I can fold around the disc herniation if I'm, the cauda equina. So Bragg and Marion said this: the cervical posture influences the strain or tension in the entire pons cord system all the way down to the lumbosacral nerve roots, okay, or the cauda equina area. So what you're seeing is here, I look at this and I go, if I was a patient and I had a disc herniation in my low back, in addition to treating the low back, I would probably want to restore my cervical curvature in my neck in order to put slack in my lumbosacral nerve roots, so then it would minimize or limit the amount of force or contact load between my disc herniation and my lumbosacral nerve roots. That's the idea shown in this particular cadaver study. Now that's not a treatment outcome study, that's a biomechanics study that in theory should apply in clinical practice. But to my knowledge, nobody actually studied that before my colleagues and I from Cairo University. So what we decided to do is take 80 subjects with chronic low back and leg pain, unilateral leg pain, due to a confirmed lumbosacral disc herniation. This is a randomized controlled study with a 6-month follow-up period. So 80 subjects, 35 female, 45 males, between 40 and 55 years of age. They have chronic discogenic lumbosacral radiculopathy, and they have also hypolordosis of the cervical spine and forward head posture. Now additionally, this group also has too much lumbar curve as measured with a postural system called a formetric system, and they have hyperthoracic kyphosis. So this is a very specific population that we're looking at. Now we only have lateral cervical x-rays, and we use surface contour for the rest of the spine. So we know 100% that these subjects have loss of the curve on x-ray in their neck and forward head posture. We use a formetric system for the rest of the spine just simply to minimize x-ray dosages in this particular study. Okay, so we don't have x-rays in the low back and we don't have x-rays in the thoracic spine, but we do have an MRI to confirm the disc herniation. Inclusion criteria: loss of the cervical curve from C2 to C7 less than 25 degrees. We believe through studies your curve in your neck should be at least 25 degrees or more. Okay, so people with less curve than that, you're in the project. Anterior head translation, you have to have greater than 15 millimeters. That means the point here on C2 relative to this green line that comes from C7, that distance there needs to be greater than 15 millimeters. They have to have unilateral leg pain, mild to moderate disability, up to 40% on an Oswestry Disability Index. And also they have to have side-to-side differences in their H reflex latency of more than 1 millisecond. H reflex is, in theory, testing the excitability of the alpha motor neuron pool. So it's a true measurement of neurophysiology. Also, visually and with our formetric system, they had to have visual hyperlordosis, aka the sway back posture, and too much thoracic kyphosis. Excluding. In this particular project of interest, we excluded true straightened necks and true kyphotic necks. Well, why would we do that? Well, what we're doing is testing the biomechanics study that was proposed in 1962 by Bragg and Marians. They didn't do cervical kyphosis to show the amount of tension in the lumbosacral nerve roots. They did straightening of the cervical curvature and showed the effects. So what we thought we'd do in this particular project is look at curves that were between straight and 25 degrees lordotic. We exclude true straight necks and kyphotic necks. Here's why. If this is going to be effective in people that have what we call hypolordosis, it should also then be effective in true straight necks and reversed necks or kyphotic necks. They are worse. They would apply more longitudinal stress and strain to the lumbosacral nerve roots. So our hypothesis is if this works in people with hypolordotic neck curves, it's going to work in straight necks and kyphotic necks because by nature they're worse. Exclude a lot of metabolic syndromes, etc. True stenosis. We don't want true lumbosacral stenosis or cervical stenosis. Exclude rheumatoid arthritis, osteoporosis, and actually any lower extremity deformity like anatomical leg length inequalities and such, because that can affect low back and leg pain as well. So here's our patient demographics or variables. You can see the age, the height, the weight, the gender distribution, whether or not they're sedentary or active, also whether or not they've had previous surgery and the medications. In essence, our two groups are matched identically. We're going to have a control group and what we call a treatment group. Here's what's going to happen in the groups. Both groups, whether you're randomized 40 subjects to the treatment group or randomized 40 subjects to the control group, both groups get this, TENS and hot packs for their low back, okay? TENS and hot packs for their low back. Now, why do we do that? Well, there's evidence that TENS and hot packs will improve low back and leg pain, at least in the short term. Also, you could call this a type of placebo intervention for the low back, but it does have a true physiological effect. TENS and hot packs for the low back. In addition, in the treatment group is going to get the cervical Denneroll to improve the cervical lordosis and anterior head translation. So the difference between the two groups is only the cervical Denneroll. Both groups have the same loss of the cervical curve and forward head posture. Both groups have low back and leg pain. However, only one group is going to get the cervical Denneroll as a treatment. Treatments are going to be applied in the outpatient department at Cairo University 3 times a week for 10 weeks or 30 sessions. No care is going to be given at home, and no care is going to be given after the 30 visits. So the treatment is 10 weeks duration, 3 times a week, 30 visits. Stop care, reevaluate, follow the subjects for an additional 6 months with no care after the 10 weeks, and then see what the results are. So the Denneroll. The Denneroll always must be prescribed by a trained and licensed healthcare provider. The Denneroll is not, I repeat, is not sold directly to the consumer or the public. Now the public will watch this video, and if you're out there, you might go, well, that's not fair. Why can't I go and buy one? Well, the reason is this is not a toy. It is specifically designed to change your cervical curvature and improve your head posture. There are clear indications of people that need the Denneroll, and there are clear contraindications for people that do not use the Denneroll. There is a risk if you use it inappropriately and you're not a candidate for it. So we only distribute the cervical Denneroll through licensed healthcare providers. So you must go to your licensed healthcare providers, and you must have a lateral cervical x-ray, and that provider must say, yes, you're a candidate for it, and also must do some exam findings on you to make sure it's safe for you, okay? So there are indications and contraindications for the Denneroll. Now in this project, we used the gray or the large device as well as the medium or white device, depending on the flexibility and the size of the subject. You take the lateral cervical x-ray of the subject, you find where their cervical curvature starts to change directions or straighten out, and then the apex of the cervical Denneroll goes at the apex of the cervical curve. So here's the same subject lying over the cervical Denneroll peak. Here's an X-ray shadow of the cervical Denneroll. You can see here's the peak of the Denneroll, and you'll notice that it does extend the cervical segments nicely at the peak of the Denneroll. So we get hyperextension localized to where the peak is in that region. Okay, so the cervical Denneroll, we have three placements. We can either place it in the low neck, in the mid neck, or the upper neck. Now, in this particular project, I believe we made a simple mistake. 1 out of 40 of the subjects, 2.5%, got the cervical Denneroll in the upper neck. The reason we put it in the upper neck is if there's an upper neck straightening. However, every subject also had anterior head translation. So when we place the Denneroll in the upper neck, you can see it also causes more anterior head translation or prevents posterior head translation from occurring. You know, there's no such thing as a perfect study design. Once in a while, you make a subtle, what you could call, well, that might be a subtle mistake. It's not an overt mistake because the Denneroll will affect that upper neck, but it doesn't allow the head posture to come backwards when the subject has anterior head translation. So likely speaking, we should have probably placed the Denneroll in the mid-neck in 11 subjects and the low neck in 29 subjects, but you'll see the results still come out quite nice. So most of our subjects get the Denneroll in the lower neck, some of them get it in the mid-neck. Now, if you're a trained provider out there, you're a chiropractor, you're an MD, you're a licensed physical therapist, etc., the Denneroll placement, it must be consistent with what you see on the lateral cervical and their posture. Also, there's sometimes we do not want upper neck extension like this subject is shown when the Denneroll is placed in the lower neck. We might have to look at we do have to look at the lateral cervical and their upper neck extension from skull to C3, and we have to decide, do we want this much skull extension while the subject's lying over the Denneroll? And that's indicated by what we see on the X-ray, and it's also indicated by the patient's symptomatology. So I might not want this much extension at the top of their neck, and we'd simply ask the person to tuck their chin down. Now, not everybody needs that, but some subjects do. We start lying on the Denneroll with 3 minutes per session, and then we're going to increase 2 or 3 minutes per session over the 30 visits until we get the subject doing 15 to 20 minutes per session. The goal is 15 to 20 minutes per session lying sustained on the Denneroll. Why? Well, that's what it takes to cause soft tissue deformation, viscoelastic creep. The soft tissues will slowly deform and stretch under this loaded position. So we can't do 15 to 20 minutes day one, but we start with 3 minutes and then build up over consecutive visits. Okay, so methods, outcome measurements. We're going to look at the cervical curvature C2 to C7 using the posterior body tangent lines. Anterior head translation C2 to C7. These are our 2 X-ray measurements. We're also going to use a 4-metric system looking at lumbar lordosis, thoracic kyphosis, trunk inclination, and this is from the side, the sagittal plane, and then these would be lateral deviation would be trunk translation left and right. Trunk imbalances would be lateral flexions, and then y-axis rotation. Patient relevant outcomes, meaning what does the patient care about? Well, we're going to look at low back and leg pain intensity on a scale of 0 to 10. We're going to look at the Oswestry Disability Index, the ODI, and we're also going to look at the H-reflex speed and its amplitude. So how fast is the signal and how many neurons in theory are involved in the amplitude or the strength of the signal. Okay, so here's an example of the raster stereographic 4-metric system to look at posture, and this is in the Denneroll group. Of interest, 10 weeks showed, the 10-week outcome showed clear, consistent, statistically significant improvements in 3-dimensional posture in the Denneroll group. The control group didn't get that. Even though the control group is lying down with hot packs and tens on their low back, they did not get the same postural improvements as the Denneroll group. So shown from the side here, here's a this is a subject in the Denneroll group before the project. This is after the project. You'll notice a change in sagittal balance, meaning the distance right here, okay, that distance is decreasing. C7 is becoming closer to the plumb line. And then also notice the thoracic kyphosis is improving, as well as the lumbar curve. In addition, look at the, this is the pre, sorry, I should say this is pre, this is 10 weeks, and then we stop care, and then this is the 6-month follow-up. So A is the pre, B is the 10 weeks after treatment, 30 visits, and then C is 6 months later. You'll notice improvement in the three-dimensional back surface topography too. Here we have lateral trunk translation to the left, a high left shoulder, and some y-axis rotation about gravity. Here you'll notice that postural displacement series is gone. So those 3 postures are improved very nicely at the post follow-up 30 visits, and then it's maintained 6 months later. Now, of course, we've picked a very visual representation to show you. Not every subject changed this much, but the whole group did show statistically significant improvements. The results continued. Now, here's the cool thing. When we look at this, you got to realize the importance of looking at not just 10-week outcomes like immediately after care. What happens after we stop care and then follow the subject, that's more relevant. So here's what we identified. Study versus the control group at 10 weeks. There are statistically significant improvements in the Denneroll group, the study group, in terms of their posture. The lumbar curve and the thoracic curve are way better. The trunk inclination and trunk balance are way better. The pelvic inclination, pelvic posture, and surface rotation, way better in the Denneroll group compared to the control group. So clear differences in the posture between the groups. Clear differences in the cervical curvature C2 to C7 and anterior head translation in the Denneroll group compared to the non-Denneroll group. Also at 10 weeks, the H reflex, amplitude, and latency are improved in the Denneroll group compared to the non-Denneroll group. So neurophysiology is improved in the group that got the cervical Denneroll, but not the group that got TENS and hot packs for their low back. Now, how is this possible? Well, we would believe that this is possible because we're improving the cervical curve, decreasing the tension on the lumbosacral nerve roots, and then the nervous system works better. Makes sense, doesn't it? It's like, it's not rocket science. If you put tension on a spinal cord nerve roots, that tension impairs the ability of an action potential or the nerve signal. It impairs its ability to fire and function. You feel it as a patient as low back and leg pain, or you'll see it if we measure it quantitatively, you'll see a difference in the speed and the amplitude of the signal. It's biomechanics. It shocks me that people don't know this. Sorry for getting a little excited. You needed that. I was being a little too monotone, right? Wake you up a little bit. So there's clear differences in neurophysiology between the groups at 10 weeks. Of interest though, check this out. This is the funny one. This is the odd one. This is where I personally went, wow, gosh, that's kind of strange. I don't know if I like that, right? It doesn't matter if you like it. You still got to report it. At 10 weeks, both groups are better with their low back and leg pain, but they're the same amount better. There's no difference in the Denneroll group compared to the control group in low back pain improvement and leg pain improvement. There's no difference in the Oswestry Disability Index. In other words, both groups are better than when they started at the end of 30 visits. They are better in their back pain and leg pain and disability, but there's no group differences. So then as a patient, you go, well, that kind of sucks. I mean, I see my posture's better, my curve's better in my neck, but I actually don't feel the difference. That's what a patient would say. And then I go, whoa, boy, that's a bummer. As a doctor, I go, man, that really sucks, because I believe that the group that got the curve change in their neck with the Denneroll, they should also feel better, right? Wrong. At 10 weeks, right after care, the next day following care, there's no differences in the way people feel sometimes. And you gotta say to yourself as a clinician, as a patient, that makes sense because you're doing things to make you feel better. What happens when you stop doing those things and follow the person? Now that's the most relevant finding. So let's see what happens at 6 months. Here's what we find. At 6 months, now there's significant differences between all the variables, including back pain, leg pain, and oswestry, between the two groups. What that means is the control group, the improvement that they got in their pain and disability, the improvement that the control group had at the end of 10 weeks Now at 6 months, it starts to fade away and it starts to go back to pre-study values. In other words, they start hurting again. Their low back and leg pain get bad again. Their disability gets bad again. Guess what happens to the Denneroll group? They continue to improve over time. So 6 months later, there's now clear differences favoring the Denneroll group between low back and leg pain scores and disability scores, and that is the wow factor. That's where we go, changing the neck curve does have a long-term effect on low back, leg pain, and disability. That's what we found. Now here's a before and after of one of the subjects in the study in the Denneroll group. This shows loss of the cervical curve and forward head posture. This shows improvement of the cervical curvature and forward head posture. Stop care, follow for 6 months. What do you find? You find the curve is maintained as well. That's what we found. 6 months later, on average, the Denneroll group, not only are they feeling better in their low back and leg pain and their posture's improved, but their curvature also stays corrected, and that's important. Okay, now, there are a few subjects that break that trend. There's some subjects that need continued supportive care over time, but we didn't do that in this project. Conclusion. This study demonstrates that the Denneroll cervical traction group showed more improvement than the control group getting only hot packs and TENS in the low back. The Denneroll group showed more improvement in cervical lordosis, 3D posture, and clinical and neurophysiological parameters. These results provide objective evidence that biomechanical dysfunction in terms of abnormal head and cervical spine positions, and not just lumbosacral pathoanatomy like disc herniations, influences the outcome measures of lumbosacral radiculopathy. In other words, don't just treat the low back. It's naive to think that one area of the spine is in isolation all by itself and you can ignore the rest of the body. The entire system needs to be reworked from actually head to toe. You cannot ignore upstairs biomechanics and downstairs biomechanics when you're working with a patient. You cannot just treat the low back. Okay? There is clear evidence that now shows that this is the case. And let me just pause for a minute. This is the part that I get so frustrated. You got insurance companies out there, insurance companies, for-profit companies, by the way, for-profit companies. Patient pays a premium. By the way, I have an insurance company too, so I'm just like you. I'm a patient sometimes. I pay my healthcare premium. But then I go to a doctor and the insurance company goes, oh, you know what? We're not going to allow that doctor to treat your neck because you only have low back and leg pain. You know what? I look at that and I go, bullshit. This is nothing more than a monetary saving issue, in my opinion, driven by the insurance company's desires to limit care and to make more profits. Because if they limit what a doctor can do, then they don't have to reimburse for it. Now, this is my opinion, and I'm entitled to my opinion, and sorry for swearing. I'm just tired of what's going on. I see a patient, or I'm a patient, and I get evaluated, and a doctor that's actually very smart and very intuitive goes, hey, Deed, you know what? I know you have low back and leg pain, but there's really a major problem with your cervical spine and your thoracic spine. We need to x-ray that area. We need to actually intervene to the whole system to help your low back and leg pain. How does that sound? As a patient, I go, that sounds logical to me. I've got some mechanics in my background. I'm trained, I'm educated. I go, hey, that makes sense to me. Well, then the claims get submitted to the insurance company and some third-party reviewer, some quote-unquote expert reviewer, decides to deny the claim because they're treating an area distal or above the area of primary complaint. This is just absolute nonsense. Clinicians and patients need to realize that, hey, you know what? The insurance company works for you. You pay their bills. They don't tell you what to do. They are your employee. You get on the phone with them, you call them up and you say, you know what? I'm not going to tolerate that. Here's what I'm going to do for my low back and leg pain. This is the type of care I want, and this is supposed to be covered under my insurance. I expect it paid for. That's what I would do. That's my opinion. Sorry for going on the tangent, but I think it's needed. The other thing is, this project in 2015, we won a research award at the WFC conference, and I just want to really thank my colleagues from Cairo University, Ibrahim and Aliyah. And sorry for swearing. I know you guys probably wouldn't have sworn like that, but I get pretty excited here in the United States over stuff like that. But we won the best randomized trial at that conference throughout Europe. And I just also want to thank the WFC team for thinking that that was a worthwhile project, and we won an original research award. So that's a big deal for us, for Cairo University and for CBP nonprofit. And then here's myself, Dr. Deed Harrison, receiving the award from the WFC research chair, Dr. Claire Johnson. And it was quite an honor to get that award from her and receive that at the conference. So that's the end of this week's CBP nonprofit research study review. Hopefully you've enjoyed that one. Hope to have that paper someday accepted in formal publication, but for now it's been accepted in peer-reviewed conference proceedings, specifically at the WFC ECU Conference 2015. Just as a last note, please consider donating and supporting CBP, donating to and supporting CBP nonprofit research. You can go to our website, check out what CBP nonprofit is all about, look at the types of studies we do. We are conservative care and spine care and patient advocates with our research. We don't do too many surgical projects, though we have funded a couple of surgical and biomechanics types projects. We're really looking at more clinical outcome projects these days, and we do need consumer and public support for the types of studies that we're looking at doing in the future. Also, if you're a patient out there, look at this information and consider whether or not maybe you need to seek out a CBP trained practitioner or provider. These types of providers are trained in the research that I've just presented, trained in the style of treatment that we do, and I know that they can help you if you're not getting the type of help that you're looking for. And the website to find CBP trained providers is www.cbppatient.com. So consider those two things, and again, happy holidays, and until next time, I'm Dr. Deed Harrison.